Hello everyone in Cardiovascular channel, and we are continuing today lifestyle optimization, and we are going to speak about mental health and smoking cessation. We have started in the last video the elements of lifestyle modification, and we have spoken about the physical activity, nutrition, and their impact on body weight and composition. Today we are going to focus about the importance of mental health in the cardiovascular prevention and the prognosis of cardiovascular patients besides the smoking intervention. Let's start with the mental health. When we speak about unhealthy lifestyle like lack of exercise, unhealthy diet, and smoking, it increases the cardiovascular risk beside negative impact on mental health, which by itself increase cardiovascular risk much more. Also, it worsens the prognosis in cardiovascular patients beside increasing suicide risk. So here, the mental health has a dangerous effect on cardiovascular patients. On the contrary, when you speak about healthy lifestyle like regular exercise, healthy diet, smoking cessation, it reduces cardiovascular risk beside positive impact on mental health, which by itself reduce cardiovascular risk much more. Also, it improves the prognosis in cardiovascular patients and increase compliance rate to lifestyle modification and medication. So this emphasizes the importance of mental health as a core component in the prevention of cardiovascular disease and its impacts on the cardiovascular prognosis, and emphasizing the importance of psychological intervention, which can be performed by the cardiologist on his initial contact to the patient regarding the patient's stress symptoms, any depressive symptoms, and sometimes he may need to refer him to psychiatrist, and this includes the patient who are psychologically stable besides the patients with mental disorders. And SUPRIM studies, the patients in the intervention group had a 41% lower rate of fatal and non-fatal cardiovascular events and fewer recurrent MI, and in a recent randomized clinical trial, the cardiac rehabilitation enhanced by stress management led to significant reduction in cardiovascular events compared with the standard rehabilitation alone, which includes speaking about medication, diet, and exercise without focusing on stress management, which is faced by many patients. So we can say that psychological intervention either by the cardiologist or the psychiatrist reduce cardiac morbidity and mortality, improve cardiovascular outcomes, alleviate psychological symptoms, increase compliance rate, and reduce risk of suicide. So psychological importance is essential to be started by the first doctor who sees a patient, and sometimes referring him to a specialist if the patient started to face a mental disorder. What about the psychopharmacotherapy which some patients may need? SSRI, standing for selective serotonin reuptake inhibitors, lowers the rate of coronary heart disease readmission and all-cause mortality, and escitalopram resulted in lower rate of composite endpoints for all-cause mortality, MI, or PCI in acute coronary syndrome patients who face depressive symptoms. So sometimes we may need to use these medications in cardiovascular patients, which would help to improve their mood, increase compliance rate, and reduce risk of suicide. But of course, it is not only pros, it has some cons. Some of the psychotropic medication may increase risk of sudden cardiac death due to QT interval prolongation, especially tricyclic antidepressants and also antipsychotic medication. And patients with heart failure per se, the antidepressants are associated with increased risk of cardiac and all-cause mortality. That's why when cardiovascular patients who has complex mental disorder need pharmacotherapy, they require interdisciplinary cooperation between the cardiologist and the psychiatrist in order to decide on the benefits versus risk of psychotropic medication and whether the risk of medication would be higher, and so we are going to depend on psychotherapy alone, or the risk of the mental disorder and risk of suicide is higher, so we are going to start this medication with close follow-up with the cardiologist. So the task force this year had a class 1 recommendation that patients with mental disorder need intensified attention and support to improve their compliance rate, and patients with cardiovascular disease and mental disorder need interdisciplinary approach between the cardiologist and the psychiatrist. There is also class 2A, that the cardiovascular patient who faces stress symptom should be referred to psychotherapeutic stress management, which would help to improve cardiovascular outcomes and reduce stress symptoms. And the patient with coronary heart disease who start to face major depression should be considered for SSRI, which would help to improve their prognosis, compliance rate, and reduce risk of suicide. And there is a big no that patients with heart failure especially who face major depression, SSRI, SNRI standing for serotonin norepinephrine reuptake inhibitors, and tricyclic antidepressants are not recommended due to risk of sudden cardiac death. Now let's move to the lengthy part of our video regarding smoking intervention. The first thing that comes to our mind when we speak about smoking intervention is the cigarette smoking, that I ask the patient whether he smokes and how many cigarettes does he smoke per day to calculate his smoking index. But we should not forget other elements that the smoking intervention targets, like cigar smoking, like shisha smoking, pipe smoking, besides secondhand smoking standing for the passive smoking. These all are elements of the smoking intervention strategy, so we need the history taking to also exclude them because they increase the cardiovascular risk. Needless to say about the dangers of cigarette smoking regarding its main component, which is the tobacco, besides the nicotine and other chemicals like carbon monoxide, lead, arsenic, tar, cadmium, formaldehyde, acetic acid, ammonia. All of these are dangerous chemicals inhaled by the smokers that we need to speak briefly with the patient regarding these dangers without speaking in a superior way that frustrates the patient from stopping smoking. We need to focus on the dangers of smoking, but much more on the benefits of smoking cessation. This would make the patient much more eager to stop smoking. Cigars are formed of rolled bundles of dried and fermented tobacco wrapped in tobacco leaf or tobacco containing material. Of course, their use is less common than in the past, but they are still used by many individuals nowadays. That's why we need to make a comparison which is more dangerous, cigar or cigarettes. So if we make this comparison, we can say that cigar contain an average of 100 to 200 milligram of nicotine, whereas a cigarette contains about 8 milligram, much smaller amounts. Cigar lasts longer as an individual can smoke a cigar for an average of 30 to 60 minutes, whereas cigar usually persists for about 10 to 20 minutes. Cigar are usually unfiltered, but some versions, of course, of cigar nowadays are filtered. Most of the cigarettes use a filter to reduce the risk. Smoke of the cigar usually is left in the mouth, increasing risk of oral cancer, whereas cigarette smoke travels deep into the lung, increasing risk of lung cancer. So if we ask ourselves which is more dangerous, of course cigar is more dangerous than cigarettes, equivalent to 20 unfiltered cigarettes. So you need to warn the patient about the much more dangers of cigars if he already smokes them. Shisha smoking, which has alternative names when you search on the internet like hookah, water pipe, according to the region where it is used. It has widespread use all over the world, and the most common reason, the misperception that they are less dangerous than conventional cigarettes due to their intermittent use. If you need to smoke shisha, you need to go to a cafe, or you need specific equipment at your home in order to smoke it, whereas cigarettes are much easier to smoke. You just have a pack of cigarettes in your pocket that you can smoke any cigarettes at any time you want. That's why some people may perceive shisha as less dangerous. Also, the social acceptance by many people that no problem to smoke shisha, but cigarette smoking is dangerous and is a stigma for the people. That's why some patients are eager to stop cigarettes but not eager to stop shisha. And the use of flavored tobacco, which of course makes shisha much more tasteful than cigarettes, and the peer pressure by friends or by my colleagues in order that when I sit with them in a cafe to smoke shisha with them. But we need to emphasize that shisha smokers are exposed to many of the chemicals as cigarette smokers, maybe in higher level or lower level according to the type of tobacco used in the shisha, frequency of use of shisha, and the heating process or the use of charcoal combustion in the shisha. All of this, of course, alters the danger of shisha to make it much more dangerous or less danger than the cigarettes. That's why we need also to educate the patient about the dangers of shisha smoking and correct this misperception. Secondhand smoke, or sometimes called environmental tobacco smoke, includes the mainstream smoke, which is exhaled by a person who smokes, or the side stream smoke, which comes from the lighted end of the cigarettes or of the pipe or cigar, which has higher concentration of nicotine and carcinogen. This, of course, has a term of passive smoking that some people are exposed to at their homes, at their work, or some of the social places. This has the same harmful chemicals that smokers inhale with no safe level so far of exposure. That's why we need also to warn the patient to avoid as much as he or she can the exposure to passive smoking. After this brief talking about the dangers of different types of smoking, let's move to the intervention strategy itself. It usually starts with very brief advice at first, performed by the doctor for about 30 seconds in a clinical intervention that try to assess the smoking index for the patient and advise him about the best method to quit smoking. So it has 3 elements. Ask the patient about his smoking status, advise him on the best ways of stopping, either stopping suddenly as most of the psychiatrists advise, or sometimes if this method fails with the patient, I can give him strategy about gradual cessation, and ACT, which offers help to the patient how to increase the success of smoking cessation. And we should not focus only on the dangers of smoking without speaking to the patient about the benefits of stopping smoking and becoming an ex-smoker. First of all, it results in substantial reduction in the cardiovascular events, especially on the repeat MI and mortality. Also, it has a lifetime gain from the age of 45 of about gain of 3 to 5 years. Also, the cessation in heavy smokers lowers the cardiovascular risk within 5 years, and the total health benefit would be larger because of gain in non-cardiovascular health, as well as the reduction in the risk of COPD, risk of cancers. So all these are benefits that the patient gain when he stops smoking, and I need to summarize them to the patient. This diagram illustrates the cardiovascular disease-free lifetime gain from smoking cessation in years. We can see here that the lifetime gain is much higher when the patient stops smoking at a younger age, and also it is higher with normotensive rather than with hypertensive patients. But what are the challenges that the patient face that may jeopardize the success of smoking intervention? First of all, the weight gain that many smokers face when they decide to stop smoking. Smokers, of course, may have an average weight gain of about 5 kilograms, and I need to speak to the patient that the health benefits of tobacco cessation outweigh the risk of weight gain. And this weight gain is usually in the initial stage, but if I try to help the patient to adjust his diet and start exercise, this would help to reduce this weight gain on the long term. And so I need to report this issue to the patient and tell him that yes, there is a risk of weight gain, but how can we overcome it? The second challenge is the craving sensation, which can result in persistent smoking with failure to stop or relapse to smoking again. And this is common in those with severe depression or sometimes with environmental exposure like at home, from their friends, their colleagues, at work. And this raises the importance of counseling, and sometimes we may need to use medication to help the patient to keep on stopping smoking. So if you want to illustrate the cycle of smoking intervention strategy, it starts with brief reiteration of the benefits of quitting, then agreeing on a specific plan to quit, follow-up visits in order to assess whether the patient had succeeded in this or whether he relapsed again. Sometimes the telephone therapy in some countries is used by healthcare workers in order to make contact with the patient to assess that he is still quitting without any failure. And some patients, of course, may need medications to help quitting, and they are going to speak now about this issue. The medications include nicotine replacement therapy, Varniculine, Propion, and Cessation. Nicotine replacement therapy include chewing gum, include transdermal patch, nasal spray or inhaler, and sometimes sublingual tablets. It helps to give the patient smaller amounts of nicotine that reduce the craving sensation and helping them not to relapse again. Success rate of nicotine replacement therapy in comparison to placebo is about 1.4 to 1.5, and sometimes use of a combination of these preparations versus single form, using a higher dose of 4 mg versus 2 mg gums can increase the success. There is no adverse events so far from this therapy in cardiovascular patients, but evidence of efficacy is still inconclusive, but does not prevent their use in cardiovascular patients to help them. Regarding Varniculine, famously known as Chantix, it is a partial agonist of nicotinic receptor acting on the mesolimbic dopamine system, famously known as the reward system in the brain, which of course simulates nicotine activity to a lesser degree than cigarettes with release of dopamine, so it helped to reduce craving and withdrawal symptoms and helping the patient to keep on his smoking cessation. At a dose of 1 mg twice per day, it increased quitting rate more than twofold compared with placebo, so its success rate is about 2.6. Beyond 12 weeks standard regimen, it is well tolerated by the patient, and so we can start it in hospital following acute coronary syndrome. Its main side effect is nausea, but it usually subsides. That's why Varniculine is one of the most successful medication in smoking cessation. Propion is one of the famous antidepressants, which is norepinephrine dopamine reuptake inhibitor, which increase their levels in synaptic cleft and so increasing their CNS action. Propion also has an antidepressant effect that help long-term smoking cessation, as it alleviates the depressive symptoms that may accompany smoking cessation with nearly similar efficacy to nicotine replacement therapy. So its success rate in comparison to placebo is about 1.4, which is nearly the same as nicotine replacement but inferior to Varniculine, and also it has a good advantage that it slows the weight gain caused by smoking cessation. Cessation also is one of the medications that is a partial agonist of nicotinic receptors in the brain, but so far its evidence for efficacy is limited. That's why it is not commonly used as the first three examples. And we need to remind ourselves that nicotine replacement therapy, Varniculine and Propion don't increase the risk of cardiovascular events during or after treatment. If the patient asks me, what about electronic cigarettes, doctor, famously known as e-cigarettes? Can I use them? I heard that they are less dangerous than cigarettes. I need to tackle this issue with the patient because they are famously used in the markets around the world. First of all, what are their mechanism? The e-cigarettes simulate combustible cigarettes, but by heating nicotine and other chemicals into a vapor rather than burning it. So it delivers nicotine, but without most of the chemicals present in the cigarettes. So yes, they are less dangerous than cigarettes. We can see a fluid present in the e-cigarettes, which is heated into vapor, and we can see this fluid through a transparent glass. The role of e-cigarettes, that some evidence that they are more effective than nicotine replacement therapy in the process of smoking cessation, to the degree that the NHS in UK approved it as a method for cigarette smoking cessation, because they are less dangerous and sometimes it makes the cigarette untasteful and disgusting to the patient, to the degree that one of my patients told me that after I used e-cigarettes, I now hate cigarettes at all. But what about their hazards? First of all, the long-term effect on the cardiovascular and lung disease need more research because they were released in the last 1 or 2 decades, so we need much more research in order to illustrate their long-term hazards. But I need to advise the patient to avoid their dual use with cigarettes. If he wants to switch from standard cigarettes to e-cigarettes in order to reduce the hazard, no problem, but this should not be a final destination for the patient. He should consider it as a stage for cessation if he cannot stop smoking suddenly, and then we are going to advise him to stop them. And we need to tell the patient that e-cigarettes are addictive because they contain nicotine, and some patients may face difficulty in stopping e-cigarettes as well. And so we can reach a conclusion that despite e-cigarettes are lower intoxicants than cigarettes, that we should not argue this with a patient because it depends on the notion of heat not burn cigarettes, but they contain tobacco and contain nicotine, and so they should be discouraged. And I should not advise any patient that he can start e-cigarettes because they are enjoyable, tasteful and less harmful than the cigarettes. No, I should avoid this, and also the use should be subject to similar marketing control as standard cigarettes, especially for the teenagers and children, because its flavored varieties appeal to children and teenagers. So the task force this year had a class 1 recommendation that all types of smoking tobacco should be stopped, either cigarettes, cigars, pipe, shisha, because they are strongly correlated to cardiovascular disease. Smoking cessation is recommended regardless weight gain, because weight gain does not decrease the benefits of smoking cessation on the cardiovascular disease. And there is a class 2A that in smokers offering follow-up support regarding use of nicotine replacement therapy, Varniculine, pure Propion, or sometimes combination of them should be considered because they may help some patients who fail to stop smoking. So our take-home message today at the end of this video is that mental health is not less important than physical health for any cardiac patient, and I need to focus on it when I deal with my patients. Smoking intervention is not just an order that you tell the patient, please stop smoking. I need to discuss with him this issue about the hazards, the benefits, the challenges, and how can I help them. Sometimes I may need to refer him to a specialist, and when you fail, of course, seek a specialist help, either when the patient feel mental disorder like depression, stress, or a smoker fail to stop smoking. Thank you very much for watching this video, and wait in the next video for lipid intervention.